It's Andrew Dowling here and Mitch Kurtz. Thanks for joining us for another episode of the AltMed podcast. Make sure to hit like and subscribe because we have way more content coming out. And you got to stay up to date with it.
It was good until you did that.
Okay. Sorry.
Hey guys, welcome back to another episode of the AltMed podcast. My name's Andrew Dowling. With me, as always, my co-host Mitchell Kurtz, aka Mitch Kurtz, aka my co-host. We have a very special guest on the podcast today. But before I introduce, just a quick note: if you do like our podcast, and we know there's a couple of people that listen from time to time, we appreciate it. Please remember to hit like and subscribe wherever you get your podcast feed. All right, so today's guest is Dr. Dev, a sleep specialist, cannabinoid clinician from the Lullaby Sleep Clinic up on the Central Coast in New South Wales. Dr. Dev, great to have you with us on the show. Welcome.
Any drums or any? Where's the audience?
We'll add all the sound effects in afterwards for sure.
All right, put the audience in later.
And the sparkler.
That is sparkler, exactly. For our YouTube audience. So what can we maybe, because I suppose sleep medicine as a field and cannabis, we get that there's crossover, but what we'll start with your journey. Talk us through it. We know that, you specialize in these fields. We also, before we were recording, we were talking about your stand-up career. So I want you to throw a bit of information in there about that as well. Let's hear it all.
Look, thanks guys for having me on board. I'm sure you'll regret every moment of this.
Already am.
Well, you have to warn your audience that this should be a parental guidance sort of setting as well. So say it as it is. Yeah, look, I'm originally from the UK. I'm from Yorkshire. I sound like Sean Bean sometimes, but I don't swear like him. But I could do if I'm about to. Bastard. So he always says, doesn't he? It's always the B word, isn't it? So graduated in the UK, was a sleep specialist in Birmingham. It's a little old town in the middle of the country where you drive past very quickly. I then came to Sydney. I was doing sleep services in St. Vincent's Hospital in Darlinghurst, which is an interesting part of the world, and absolutely fabulously enjoyed it. That was 2013. And then 2018, I was continued doing my sleep work for Lullaby Sleep Clinic, and then discovered medicinal cannabis really in 2019, 2020 as a treatment option for insomnia. I've always had a bit of an insomnia, mental health interest, and it's always been the toxic drugs we give out or had given out, like benzodiazepines, antidepressants, Seroquel, and then medicinal cannabis, and the journey's been just amazing. So yeah, that's my background, sleep specialist for about 20 plus years. So I've been around the block a few times, around the clock a few times, definitely. So
well, what did they? I'm just interested. There's so much to unpack there, but before medical cannabis was legalized in Australia, as someone who was practicing in the field of sleep medicine, what would you have prescribed someone, say, I don't know, 3 or 4 years ago for sleep?
Well, it's interesting because things like mental health and pain, which is the two biggest indications for medicinal cannabis, don't go away when the sun goes down. So all that occurs at night time. It morphs into something called insomnia, again, to sleep, staying asleep, unrestorative sleep. So, and we spend a third of our lives asleep, so if something goes wrong. For me, sleep are particularly relevant to medicinal cannabis. I think there's 4 aspects of sleep problems. I forgot what your question is, but I'll just continue, I think. So there's 4 aspects of sleep problems. One is the busy brain, as I call them, the hyperdrivers. They're the ADHD, the anxious folks, the PTSD, the bipolars.
Mm-hmm.
The second group is the fragmented sleepers. So very entrenched, broken sleep. So they're depression, Parkinson's disease, Alzheimer's, chronic pain. Third group is the restless sleepers. So They're the sleepwalkers, the night terrors, the nightmares, the acting out dreams, the restless legs, can't get to sleep until 3, the delayed sleep phase. They're just busy all night long, drives the hell out of the person lying next to them. And the fourth group is the noisy sleepers, sleep apnea and snoring. I put that in because many patients of mine with mental health, they go on these toxic drugs and they put on 20, 30 kilos olanzapine, clozapine, for example, and then they all develop sleep apnea. So those are the 4 basic quadrants of sleep, and a lot of them do fabulously well with medicinal cannabis. So answering your question, I remember what it is now, actually. We used to, I mean, the usual suspects, really, benzodiazepines, diazepams, and these others like zolpidem, zopiclone, are dreadful drugs, really. I've never in my career ever initiated anybody with zolpidem. Diazepam, yes, but I'm trying to wean everybody off them. So I've only got a handful left on these medications. The beauty of medicinal cannabis, CBD and THC, and we can talk about the impact on weaning off benzodiazepines, and it's very successfully possible to do so. It does allow people to come off the benzos. The other ones that more psychiatrists prescribe is Seroquel, mirtazapine, amitriptyline, and the side effects are not pleasant as well. So, and then, if you've got ADHD, for example, they all have busy brains, they all have sleep disruption, and they wake up in the morning 20 meters behind anybody else, but they rely on Ritalin and amphetamines to get to the finishing line. So surely, trying to get to sleep better, you start fixing your sleep when you wake up in the morning. So if it's anxiety, ADHD, hyperarousal, busy brain, something like CBD really helps to bring that flight down. And then in the evening, CBD plus or minus THC works extremely well. So you have to treat insomnia with a 24-hour strategy, which is the beauty of sleep medicine. And because I've had the mental health interest, that's why I think medicinal cannabis has been an absolute revelation and a revolution, in my practice.
I was actually going to ridicule Andrew for saying what you used to prescribe as though you don't do any of that anymore, but now I'm starting to get the impression that you possibly don't.
Yeah, I don't prescribe those anymore. No, I don't. I mean, look, the sort of patients that I see are, 10% of the extreme end. So majority, if it's managing stress, managing anxiety, clinical psychology, psychotherapy are fantastic. And let's not forget the importance of just trying to switch off, relaxing, listening to YouTube, maybe. That will certainly, hopefully, be a great form of meditation, although most people fall asleep during meditation, in my opinion. But the thing is, you can't do meditation in your sleep. You can sleep during meditation. You can't do yoga in your sleep. So for those who have the busy brains, and the EEG that you do in sleep testing clearly shows they have this hyperarousal, hypervigilant state, or very fragmented sleeping if they've got chronic pain, Parkinson's, and so on. Then crossing your legs and singing a few songs and dinging the bell isn't going to help, mate, when you're fast or trying to sleep or in sleep. So that's where I think medicinal cannabis is an alternative. Drugs like melatonin, it doesn't help either. It might get you advanced to your sleep by a short while, but it doesn't actually reduce the hyperarousal, hypervigilance state, particularly in the PTSD folks, where medicinal cannabis has been a revelation, in my opinion.
Wow. Yeah, absolutely. I was going to say they could probably just tune into this podcast, and that when anything that me and Andrew say, they'd fall asleep in moments.
Absolutely. My wife said, just record yourself for an hour. I'll put anybody to sleep, So I was
well, actually, would your wife describe that as restful sleep, or is she?
She doesn't want to talk to me anyway after 25 years of marriage. It's like it's avoidance strategy. It's been like social isolation in our house. That patients with anxiety.
She's got delta waves while awake.
Yeah, absolutely. Yeah.
So in terms of the actual research that's been done in the field of sleep medicine, what do we know about how cannabis works across maybe those different categories that you were just describing? And are you generally, because I have heard a few people or doctors saying to me that THC can, if used in excess, it may put someone down for the night, but they're not getting a good quality of sleep in the same way that someone that drinks too much one night that puts themselves to bed or passes out, they're not getting a good quality of sleep as well. Is that your view? Are we really talking about CBD predominantly when we're having this discussion?
Oh, look, there's again, you've got to understand the physiology that's causing the sleep disruption or insomnia, or the unrestorative sleep. The sleep disturbance is a secondary phenomenon to the primary problem. Whether it's mental health, whether there's pain, whether it's multiple sclerosis, whether it's Parkinson's disease, or Alzheimer's, whatever. So the sleep is a secondary phenomena. So you have to understand the physiology. Once you understand the physiology, you then get an idea of the psychology, and then that gives you an insight of the pharmacology. It's called precision medicine. It's not wishy-washy medicine that many people and some doctors still think it is. I just had a social thing with a handful of doctors, and one of them said to me, I can't remember, it's probably a surgeon, haven't quite worked out what medicinal cannabis is, and he said, what's going on in the world of medicinal cannabis? I said, oh, look, I've been doing a bit of my own sort of social media stuff on LinkedIn, looking at reviewing the latest research. And this guy said to me, it's just honest, he said, what sort of new research is there that it just gets you stoned and high? I thought, all right, mate, well, it'll be interesting to see what research will be available when I stick this bong up your arse and see what pain threshold and visual analog scores will be, seen in our research data, mate.
You'll need to perform surgery on him after you do that.
I thought, well, any anal stretch will probably need surgical resurrection eventually with that bong. But, that's the sort of crap that I get regularly. So there is, thankfully, growing research on sleep. Yeah, sure, 3 years ago, people say, well, what's the research? What's the research? It's like a broken record. Some doctors still say, what's the research? But there's some great trials have come out, certainly in the last 12 months, showing certainly CBD and THC. So the trials that from the Adelaide group and one from Western Australia group. And, there's a lot of debate at the moment, CBD versus THC with CBD, and, a lot of trials going on with CBD to get them on the Schedule 3. The thing is, you have to understand what the primary driver is. It's a hyper driver. So CBD, as you know, is very good at reducing the hypervigilance, is very good at reducing the hyperarousal state, modifying serotonin, et cetera, et cetera. So for that group, the anxious ADHD folks, CBD works very well at a reasonable dose. I know there's an argument about, well, surely more than 150 will only work. None of my patients on CBD where it works are on more than 100 milligrams at night. So I think there's a little bit of a, feeling that, we have to go big. It's not big that makes it happen. It's getting the right dose for the right person, the right, medication. But there are the group like these fragmented sleepers, the Parkinson's particularly. That's been unbelievable. CBD with THC in that group, because that THC modifies dreaming. Not my feeling from the literature that I've seen. There's some trial a while ago looked at, well, does it reduce REM sleep? But I'm not convinced it does. It works through the amygdala part of the brain, which controls the visuals in the cerebral cortex. So it modifies. It's almost like it's like a gas fire that all these visuals come out. What it does, it just sprays a little bit of, just dampens down that gas, so it modifies the dreaming. For me, THC, when it comes to nightmares in PTSD, is the only drug on the planet that works effectively in PTSD, which is why the PTSD hyperdriver, they need the CBD in the day, particularly for the anxiety, panic attacks, triggers. Sure, flower might be, but the CBD with the THC works extremely well for sleep, for nightmares, flashbacks. All the other toxic drugs don't work. Seroquel or clonidine, or benzodiazepine, they just don't work because it doesn't work through the amygdala. So so the research that's coming out is showing that certainly CBD with THCs does work. I think whether or not we'll find out later when we get the CBD only researching sleep why there wasn't the signal that it works. And I have to question whether it was the right group that was targeted. So many people with anxiety, they don't necessarily regard themselves as having insomnia, spending hours getting to sleep and hours staying awake. They have 6, 7, 8 hours of sleep, but it's crap sleep. It's unrestorative sleep. It's hyperarousal sleep that is skimming the surface of a pond sleep. But if you're entering a clinical trial of sleep, then the prerequisite is that insomnia is defined by initiation, maintaining, early morning wakening, fatigue, and so on. So you're only going to get the fragmented sleepers probably in those CBD trials, but they need THC. CBD is not going to work for that group.
Yeah.
So I think it's probably lack of respect of how complex sleep is. Sleep is a complex physiological disorder. Makes me feel very wanted, actually, which is quite nice. Very, useful on this planet. But you have to treat sleep with respect. Treat it like an ID, respect, nurture it, caress it, treat it, just tailor it to the right individual. And that's why understanding the physiology will give you an idea of the psychology, which will give you an insight of the pharmacology. I'll rest my case, Your Honor.
I love it. Absolutely love it. What do you, sorry, Mitch, you go.
I was going to say, obviously there's a lot more research and experience, I guess, in your prescribing history, and also just generally out there on CBD and THC. Do you find, or do you end up playing with any other compounds in cannabis beyond the two major cannabinoids?
I think CBN is very interesting as a sedative. I think that'll be really interesting to see what that data shows, whether you can combine that with a bit of CBD and a bit of THC. It might allow you to reduce the amount of THC. All my patients who were on like the 10-10 or 25-25, they're needing quite big doses of THC, but they're getting to feel a bit groggy in the morning. So I think adding a bit of combo therapy, and I've never been a big fan of THC on its own. I'm not a big fan of people who just overshoot the THC sort of thing. I think the CBD is it's like bad cop, good cop. The CBD is the good cop, but we all want to talk about THC because it's the bad cop. CBD is the critical chemical in just stabilizing our balance and that homeostasis. We talk about the optimization, because once the boat stops rocking, then and all the water that's coming inside the boat, and you just sort of get in the bucket out. Once you stop rocking, then you're not going to get those issues. And the THC is just in addition. So I don't do THC on its own just for purely sleep. The CBD is critical, whether it be just in the day and then THC at night. So, but I think CBN, what it could do potentially, and I'll be very exciting to see this, is where they can drop the amount of THC that you needed at night for sleep, so you don't feel as groggy in the morning. Because one of the reasons why, and there's lots of reasons why patients of mine don't continue with medicinal cannabis, cost is one, and so on. But the other one, obviously, is the grogginess feeling. I just wonder a combo of CBD, bit of CBN, bit of THC together works very well. I think watch this space.
But is it fair to say as well that grogginess is also a side effect of a lot of those other so-called approved conventional drugs to treat sleep disorders, like people that take, say, Seroquel or temazepam? They can wake up feeling totally dissociated, and
for sure. But I would say that those who are on, if you're on a bit of CBD certainly doesn't, unless you have an enormous doses maybe. But CBD with THC, if you hit the right spot. And I think the other thing is, many of my insomniacs, particularly the anxious folks, they're very hasty. They'll say they'll sort of slam my table with their fist, and they'll say, "I've not slept for 30 years. What are you going to do about it?" That's what they say to me. And I go, "Well, hey, I said, well, I'll fix it, but but you got to be patient in this. And why is it taking you 30 years to find me anyway?" So But and then you start off and you say, go slow, go low, the usual sort of stuff. And then within like 2 weeks, they're on like 20 milligrams of THC and whatever it is. And then they ring and say, look, I feel crap, I feel terrible, I'm going to stop it. So, okay, well, let's just go back a bit, So I think it's very important what I do in my practice is I give them instructions. So you've got to go slowly, and eventually the grogginess will diminish gradually. Obviously, it is dose dependent. But I'll tell you what, though, for those who are on huge amounts of Seroquel, like 200 milligrams plus lorazepam and benzodiazepine plus mirtazapine,
Yeah.
mate, who's the safer driver? We talk about driving because this is a real gets me going. Already started getting going, but actually really get me going. The guys have only had 3 hours of sleep. We've been on lorazepam, clonidine, mirtazapine, shit like that, with 3 hours of sleep, getting a motor vehicle. Well, who's the safer driver, mate?
Yeah. It's crazy, isn't it?
It's my case here on that. So,
well, I'm interested just on that. Do you, I guess, what would be the most kind of dangerous drugs in terms of their side effect profile? What are the ones that, as you say, you're weaning patients off, these patients that have been on those drugs for many years, but what are really like some of the worst ones? I'm just curious because I think a lot of people who might be new to learning about medicinal cannabis just might be interested to hear about this, about the side effects from drugs that are approved by our medicines regulator, the TGA. And then we can, of course, examine the relatively low harm profile in comparison for a lot of medicinal cannabis products, particularly CBD. So, yeah, what would be some of the worst culprits?
well, I mean, they're all culprits in a sense, but not everybody has side effects. But like antidepressants or SSRIs, as they're called, or tricyclic antidepressants, I was a handful that will have terrible side effects. I mean, I've known patients on venlafaxine who've had severe constipation that have ended up with bowel obstruction and ended up in intensive care unit. Then mirtazapine and the weight gain, I think that's a terrible side effect.
Yeah.
The tricyclics like amitriptyline causing blood, vision, and urinary retention. That's a terrible side effect. The sedating effects of benzodiazepine. So, I mean, doctors don't, obviously don't prescribe these drugs, to they may not know what the side effect is, but the problem is that we're not choosing the right drug because we don't understand, particularly in insomnia, we don't understand, well, what's driving the insomnia? So, and the problem we have in medicine is that we like to label people because it makes our lives easier. You like to compartmentalize patients. So, you could be someone with ADHD, or you could be someone with bipolar, you could be someone with anxiety, you could be someone with PTSD. And that sort of makes your life easy because if they've got ADHD, you give them Ritalin. If they've got bipolar, you give them lithium. If they've got anxiety, you give them Lexapro. If you've got depression, you give them sertraline. Or if you've got PTSD, you give them clonidine. But they don't actually work out, well, what's the physiology that's driving all of this? That's really my point. There's a bit of guesswork that goes on. Lithium didn't work. All right, that was toxic for you. Well, let's try something else in big dose, and you escalate the doses. And it sort of staggers me how many patients just end up escalating the dose. Oh, it's not working. All right, then tweak it up. All right, tweak it up. So.
I was gonna say, like, when you're comparing side effects, and you might be comparing side effects kind of in jest, but also not, about feeling good or a bit of euphoria or being high, essentially, which was kind of what you were saying some of your peers were almost ridiculing you for in terms of prescribing with what are you going to do, get them high? But at the same time, it's kind of like, traditionally, cannabis is known as a sedative. I mean, obviously there is a range when you're talking about sativa and indica, But generally speaking, we see it as like something that lands you on the couch. Like it's known for not making you particularly active. Like there's always that joke that gets thrown around when you're talking about it as a performance enhancing drug in sports. People are like, yeah, like performance enhancing to sit on the bench because you know what I mean. It's a performance decreasing kind of thing. So, but I like in a way that's kind of the evidence as old as time that it has that kind of sedative effect, if that makes sense.
Sure.
So I find it strange that knowing that other colleagues of yours might not even consider that factor, which has been around for thousands of years. We know it's basically used for sleep casually or colloquially or recreationally even.
Yeah, obviously, if you're smoking marijuana and there's a huge amount of THC in there, that's sedate you, and then if you're at a risk of a psychoactive effect, or a bad trip, whatever. But sort of what we're trying to do at obviously much lower dose, like 1 mil over 10 milligram per mil, 10 milligrams of THC is nowhere near how much THC will be in a strong flower in a cone, for example, or a dosing capsule. But what you're trying to do is that's not what we're trying to achieve with all of this. What we're trying to achieve is being medicated, rather than being a little bit out of sort. So it's all about being medicated to the extent where it does achieve what you're trying to achieve with pain relief, with anxiety relief, with insomnia relief, and so on and so on. And that's the beauty of the medication, because you sort of treating all facets of the lack of wellness that an individual have. Like, the Parkinson's, for example, they all have mental health issues, they all have insomnia, they all have pain as well. And so this medication, which comes in a bottle, will treat all of that. All right, it won't treat the Parkinson's per se, but it treats all the symptoms. Now, traditionally, we'd have given them an antidepressant or a SSRI for the anxiety. We'd have given them an opioid for the pain, and we would have given them a benzo for the sleep. And that's what the change is. That's where the evolution and the revolution has taken place, that we are now substituting with a better alternative. I would say 70% of my patients do feel a lot better. There's 30% that won't, or stop. And for whatever reason, it might be cost, it might be is ineffective, the pain is not as well controlled. I've got to say, in sleep, the data is absolutely compelling. And that's been the case since the early trials. In pain, the sleep always gets better. I mean, it's quite remarkable. I mean, I'm so lucky to be a sleep specialist, not a pain specialist, because the jury's still out. They're still arguing amongst themselves in their ivory towers whether it works or not. Of course it works. That's the thousands of people. But for the sleep guys, they say, this is the best thing since sliced bread. Oh my God, don't need to prescribe all that crap that we used to prescribe the last 20 odd years. It's a revelation. Absolutely. It's unbelievable. I can't believe that, they say 60% are for pain, clearly. Yeah, but insomnia, 10% of the population have insomnia. Surely, the number of SASP forms and prescriptions for insomnia is going to escalate when they realize that. It's absolutely compelling. Now, the trickery is, do you do a bit of CBD or do you do a bit of CBD with THC? That's the art. We know the science now. This is the art. And unless you've done a little bit of medicinal cannabis medicine, you'll then learn the art of cannabinoid medicine. The science is there. Don't look far. The art is the key thing. And that's why I'm hoping a lot of doctors that I'm mentoring that's coming through will. I've been doing this for 3+ years. I've had 3,000 patients that I've assessed for insomnia, medicinal cannabis, but eventually it's like a little ripple. Everybody's going to get to that stage and we'll be all in a happier place, I'm absolutely sure.
So, and speaking to that art form, I'm curious, when you're talking about the balance between THC and CBD, what about the balance between types of products, oil, flower? What are your viewpoints on that? Because obviously we see a lot of flower coming through the ranks where people get somewhat skeptical and start, blurring that line between, let's say, a medical dose and a recreational dose. And I guess it is hard when people kind of, or other doctors joke around that kind of recreational side, one of the reasons it's like that is because it's easy to have a recreational dose and not fear any serious like fatal or the harm profile is pretty low, is what I'm trying to say.
For sure. Look, one of my therapists is an ex-cop, and he looks after my cops that I have PTSD. I look after all the military and the DVA. But David, who's my ex-cop therapist, you ask him when he was level 1 command in the New South Wales Police Force, and he had a choice between going to domestic, where you got 5 blokes sitting singing a few Jimi Hendrix songs stoned out of the face with a bit of whatever it is, or you got 5 people causing violence and throwing bar stools at you. Which one would you prefer to go to, mate? So there's definitely is that safety profile compared to alcohol, definitely. But the thing is, though, as a medic, and people might say it differently if you're a pharmacist, or you differently if you're in industry. But as a medic, I think there's 2 groups that come my way. You got the group that want a solution to the problem, and then you got a group that just want pot. Sorry to say, mate. Now, I look after the people who want solutions to the problem, and I've talked about the physiology and the psychology and the pharmacology. If they want pot, sorry, mate, I can't help you. And if you ask me, out of all my patients in my practice, what proportion are on flower, it's only 15%. Flower is not the be-all and end-all panacea of treating wellness. The oils are CBD, and I talked about how important CBD is. It's an absolute giant of a cannabinoid with a THC for the right people. And then I will add on the flower if need be. And the flower, particularly in my practice, the PTSDs with insomnias and the triggers and the anxiety and the acute pains, etc., works extremely well. But it staggers me how many people are prescribed flower and just flower and different varieties of flower, but they're just probably just that's what they're after. Now, there's clinics and that will serve that group, and your pharma company will make a lot of money out of flower. It's a huge market, and there's a race to the bottom with the flower for the pricing. Buy 2 get 1. Another one free. I don't know if that's what's on the way, but there's a huge race to the bottom with the price. So the oils haven't dropped by half. They're still between $150 to $199 for 30 ml bottle, 100 milligram per ml CBD. But the flower is I'm amazed how much flower is prescribed. But if I had a stoner who was on some weird shit again from the streets and the spraying all sorts of crap on it, clearly flower is the right health option for them. But why are they on the flower in the first place? 500,000 Australians smoke marijuana for medicinal purposes, PTSD, chronic pain, you name it, mental health. Now, surely getting them onto quality flower is going to be the right thing for them to get off all the synthetic stuff that's available out there. But then you're having a conversation with, well, let's treat your PTSD, let's treat your chronic pain, let's do the oils, because otherwise you're going to go through 3 grams, a day. And if you've got a 10-gram jar, that's 3 1/3 days, per jar. That's an enormous amount it's going to cost them. But the thing is, that's what they're used to. If you're used to driving a Maserati, you're not going to drive a car like I do, a Toyota Yaris 1.4 manual with a dent in the back, with the cheapest petrol, in there. But that's what I'm used to. I don't drive Maseratis, but the Maseratis won't drive a car. If you're used to having 20, 30 cones a day, and you've done that for 20 years, that's what you're used to. It's all to do with mindset. And that's where the doctor's so important in trying to change that mindset. Okay, let's have a look at why you're doing this. But a lot of these guys, I just want replacement. And then they have pot after jar after jar. God knows what they're doing with it. Probably selling it. I think that's going to be a huge problem as prices fall. You know, a 10-gram jar, $99. That's unbelievably cheap compared to what you get on the street. And they'll just sell it. So there's a huge regulatory problem, I think. But how I'm not a regulator, and I'm not an adjudicator. I'm not an abdicator. I'm trying to think of all the words that sound similar to that. But I'm not bad, actually. Not 6 o'clock in the evening. So.
But in terms of thinking about, you know, some of the reasons behind, like, what's your view on kind of the clinics and the companies that are bringing this to market? Like, how do you view the interaction between the pharmaceutical companies that are really driving force behind some of these prices and the online telehealth clinics that make it easily accessible?
Yeah, I mean, where do I start? Look, I'm saying as a clinician, I do work with a number of pharma companies. So a lot of them I have great B2B relationships with them. So, but you know, there's that's the propagation of a number of pharma companies. They all want to get a slice of the pie. You want to make a quick buck. That's what it is. You know, apart from one company which will name nameless, the rest of the share prices have been trash. You know, like 16 cents a share. You know, so there's clearly a driver of profit making. Sure, you want to expand. You want to have a workforce and so on. But I'd get these pharma companies. They'll come to me and say, "I've got 2 new flowers." I said, "Oh, really?" Yeah, one's called Mumbo and one's called Jumbo. And Mumbo Jumbo, really? We've got another one, haven't you? Yeah, that's called Dumbo. Oh, you got Dumbo, Mumbo, Jumbo. Far out, mate. So what's the difference?
I like gumbo.
You want a gumbo?
Yeah.
Tumbo. It goes on, Tumbo. One's 19%, one's 20%, and one's 21%. Wow. Yahoo!
Yeah.
And here's the terpene profile, little wagon wheel, a bit of orange, myrcene, a bit of croflin green, really. So have you tried your mumbo jumbo to any, like 100 patients and got the feedback? No, but it's really good. And you get the flavor. All right, what's it treat? It treats it, and they got the list. Here we go. They got the list. They got inflammation, anxiety, hemorrhoids, and it goes on.
Yeah.
Yeah, but what about the patient's perspective? And I think we don't think about the patient perspective. And I think that's where all the pharmacogenetics will come in. I think that'd be really interesting to see how can I talk about precision medicine, how do we precisely, I've gone off a little bit of a tangent again, but how do we get the right flour or oil or whatever for the right patient? So look, there's an absolute tsunami of flowers, but the medics are simple people. We're simple people because we're very logical people. We can't complicate the lives of patients where their lives feel overwhelming. So we like to simplify their lives by saying, take this oil or take this and do it this day and that day, and that's it. So we like to simplify. So if you've got so many issues with regard to different types of flowers, it just complicate things. So I don't know if that sort of answered.
Yeah, well, you can't be giving him mumbo jumbo. You know what I mean?
Yeah, they need Dumbo.
You like that one, don't you?
No, actually, yeah, I do.
But that's what I'm getting. Okay, going back to the farmer, you said to me, if you say to me, well, how do I choose which pharma company to go with? It's a story. I need to know the story. Is your story just to bring products from South Africa or Denmark or wherever and sell it as mumbo jumbo and then say wholesale price $125, RRP $135? Well, that's pissed off the pharmacist, hasn't it? Where's the margin? They're not going to. So you say RRP 135, but the pharmacist's not going to sell it for 135. They sell it for 155 because they need to pay the pharmacist to dispense it. And as you know, Schedule 8, you've got to go through all the safe script and stuff in New South Wales and Victoria. So you've got to check they're not being double dipping and whatever. So there's a lot of time that takes place. So I need to know the story. If you look at the websites of different pharma companies, not many will actually show where they are, like contact, and there's like a fillable form when you do the email. Well, where are you? Where the heck are you?
Usually.
So, but if you need to know the story, you need to know who is running the ship. What's their B2B strategy as well as the B2C strategy? What's their why? It's a Steve Jobs thing. Why you're doing this, for what purpose? I want to make people better and less painful, less in pain. Sure, but why? What's your story? So
read a bit of Simon Sinek and get it in you.
Yeah, he's fantastic.
Yeah, he's unbelievable.
The people are the product is certainly key, but it's the people in the company that are as important, if not more important. What's their moral compass? What's their vision? What are you trying to do? Is it just a matter of let's get the shareholders happier? So
no, I completely agree. And we know that there is so much variability across the board in terms of all of the different sponsors, and we've seen those that have come to the market just flogging really cheap and nasty products. And then we know that there are some that have a story to tell, that have premium products, that they can back up, with the story and with the certificates of analysis and all of that. So I want to turn
and the research. There's a few companies that are putting a lot of money in at huge risk to do the clinical trials because they know that the research and the clinical trials and the peer-reviewed papers is where we take this to another level. Because I do regular GP meetings, and I would say out of 10 GPs are listening to me, only one of them will be interested in prescribing. Now, how do you get the other 9 to even consider it? They'll say, it's not what I want to do. I'm too busy. I'd rather send patients to you, Dev. I haven't got time. I can't have all your patients knocking on my door. My job is not seeing. I'm not scalable, mate. I'm completely saturated, which is why I'm taking on more doctors. But the part of that is mentoring them, teaching them, empowering them, engaging with them, educating with them, so they're the next Dev 2. Sound like a Scud missile, doesn't it? Dev 2. Probably like Elon Musk will probably explode in the air after 9 seconds. I don't know.
Causing mass sleep destruction.
Mass sleep. Yeah, absolutely. So the research is critical to get the next crop up to speed.
Interestingly, though, the research is, in theory, somewhat risky. I mean, there's always going to be a medical market, but what happens in the recreational alternative? That's it.
Fascinating.
But I am curious as well. I mean, one of the things that I think concerns people is the nature in which, even if we have research data, we have seen time and time again, we talked about all those approved drugs, I say approved in inverted commas, because they have been given the green light for the Australian taxpayer, to subsidize through the pharmaceutical benefits scheme their delivery into the hands of millions of Australians, and have caused so much harm through side effects. I mean, weight gain, suicidal ideation. I'm just cherry picking some of the side effects from approved drugs. Constipation, you touched on, on that before. So my problem is,
you worded that weirdly.
Constipation.
Good old constipation. I've been sitting on that for a while.
Touched on that.
Humor.
Yeah. So my concern is really just that even in medicinal cannabis, data can still be manipulated by the sponsor. There is always the perverse incentive to get the green light, to get the medicine registered, to get public funding for it. At least in the case of medicinal cannabis, I'd have more faith in the fact that these medicines wouldn't have anywhere near the side effect or harm profile as some of the existing approved ones. But there's just something that doesn't sit right with me, Dr. Dev, that Australians are paying for harmful drugs just because they're on the approved list.
Opioids,
That this
unbelievable.
doesn't work for me. I don't know about you, it just doesn't work for me. I think it's
I was doing a bit of aged care stuff, and there's a white paper on Royal Commission paper on aged care. What happened to that? Not everybody's put in the bottom drawer somewhere, with rest of rest of all the old white papers.
The white and grey paper.
White and grey paper. The old Tottenham Hotspur sort of magazine. You've got from 1976. So,
I wish
it categorically said that drugs like risperidone should be weaned off. They didn't say what alternative that should be. Clearly, hello. THC and CBD, particularly in the Alzheimer's group. Well, what happened to that? So we are a little bit, I don't know, we just snail's pace. Look, compared to my homeland of England, where they just, still struggling, with, the bankrupt health service, but they're well behind. I think Australia is going massive paces, but we can get it better. We can really get this better. And so when I was doing a bit of the aged care sort of work, there's about like 50 to 60% of those aged care patients were on opioids. We're not talking about a little bit of Targin, but we're talking about Norseman patch, fentanyl patch, oral morphine. Plus, it's like, it's unbelievable. I think that's where I think we'll really have to, the harm reduction has to be, you have to look at ourselves and say, what is this shit going on there,
Yeah.
But what do you think about it on the other end of the spectrum? Like, obviously, for the older patients, I get that. What about younger patients or children? Obviously, we see a lot of, just don't go there. Under 18, don't go there with cannabis. But yet, there's a lot of risperidone and benzos and all sorts of maybe less benzos, but different SSRIs, things like that, being prescribed to younger patients.
Oh, for sure.
What are your thoughts around that?
Yeah, look, I've still got a handful of children on my books. My wife's a pediatrician as well. She looks after neurodisability, cerebral palsy, and there's crying out for alternatives to risperidone. Risperidone in a 5-year-old, Christ's sake, You're right. I think that's going to take off. I really, really think so. I think it's going to take off massively. I know there's been a new ruling about THC in under 17s. And look, most of certainly the data that's out there, like in autism, CBD with 20-1 ratio of THC. We're talking about tiny amounts of THC. And, we're talking about, if you ask pediatricians who look after neurodisability, very disabled children with cognitive issues, learning difficulties, they're saying, well, THC might cause brain development issues by the time they get to HSC. I'm sorry, this kid ain't going to do HSC. And you ask the parents, who are absolutely at the wit's end. And when I do see children with autism, I end up treating the whole family. Mum, dad, the cat and the dog, they're all got anxiety. The fish, the tropical fish.
Yeah. Everyone gets a bit of mumbo jumbo.
Bit of mumbo jumbo for the tropical fish. That's the skin bleaching, So the whole you have to treat the whole family, and this is where I think medicinal cannabis. It's not about the patients you treat, but the families.
Yeah,
it's a family, and anybody out there who've had children with mental health. Oh, mate, you tell, you ask the parents what they're going through, or a patient with PTSD. So the cops that I have with PTSD, all the children have PTSD. They all have secondary PTSD. Well, what about them? You know, so you then end up treating the whole family as a unit holistically. That, for me, is the why, answer to the why question of why we're doing this, because you're making families better and functional and moving on in life, you know. And I think that's where the beauty of, you know, it's like you got a patient with Parkinson's disease, you're going to give them Parkinson's medication, but you're not going to give that to the daughter who's the carer of the Parkinson's patient. But you can give them CBD and THC to the dad, and then the daughter has a CBD so she can sleep all right at nighttime and not struggle with anxiety. What other drug on the planet allows you to treat the whole family, including the CBD in pets? I mean, that's another thing as well.
Yeah, that's starting
unbelievable.
to take off as well. It's
Just incredible stuff. I've been in medicine for 25 years or 20 years. You know, despite my good looks, I mean, that's all plastic surgery and bondage implant. Expensive. Wouldn't recommend that to anybody. But I've been around the block a lot, and this is the first time I've seen anything like this that has changed lives.
Yeah,
not ruined it, changed lives for the better. There you go.
well, and you know, I guess to come full circle, these medicines, the goal from your perspective, you're brought in, you know, seemingly to manage the sleep part of a patient. But as you say, that could be their sleep disorder could be secondary to a primary issue that they're facing with pain or you know, or anxiety or all manner of things. But I'm just curious, when we do look at sleep in isolation, do you have any kind of tips for our audience as to how many hours a night someone should have? I've heard Matthew Walker give a view on this, and then I've heard people ripping him down and criticizing his book. You know, I don't know if you have any thoughts on him, but he's apparently one of the sleep experts.
Or an anecdote from a patient, obviously anonymized, but an example of what might happen if a person comes to you and is, you know, I'm on XYZ, take them off, put them on cannabis. What could they expect to go from to?
Yeah, look, answering Andrew's question of how much sleep we need, the answer is enough for you to get through the day without needing a nap, and to focus, concentrate, and be productive. Now, that could be 6 hours, could be 7 hours, could be 8 hours. But the people, those who've got fragmented sleep and broken sleep, you know, they may, you know, I'd rather have 6 hours of quality sleep than 10 hours of their sleep. So, and it's all to do with how they function in the day. You know, 1 in 5 road traffic accidents related to fatigue or falling asleep on wheel. So, you know, there's a broader economic, social, philosophical sort of aspect with sleep. And what Mitch is saying, you know, typically, like the ones I said, whether I haven't slept for 30 years, and they I mean, they didn't get it for Christmas. They can live with it, but they've had enough, and they've had enough. And I think the more and more are coming through because they've just had enough of feeling tired of being tired in the day, you know, unproductive in the day. And there might be a particular precipitant to why they want to seek help. Maybe they have fallen asleep at work or driving or whatever. So I think the key thing is improving, obviously, the social media aspect of, hey, look, medicinal cannabis does work. It's not mumbo jumbo, you know, hocus pocus medicine, which is why podcasts like yourselves are important. Because they say, well, look, I think I don't want to live with insomnia anymore. I don't want to live with pain anymore. I don't want to live with anxiety anymore. And they do feel better in the day. They focus, concentrate better. And a lot of people who have been labeled as ADHD haven't got ADHD at all. So I get people with ADHD or labeled as ADHD, they're on huge doses of Ritalin, and then you get them to sleep better. I say, why have you got ADHD? Why do you think you've got ADHD? Because I wake up feeling crap and I can't focus, concentrate, and I'm distractible all the time. All right, well, if you got your sleep better, so you're not waking up 20 meters behind anybody else, and then invariably, the amount of Ritalin they take falls. And then people who are on all the other toxic drugs I talked about, they wean off, like the benzodiazepines, eventually. There's no other drug on the planet that, apart from CBD and THC, that would allow someone to wean off benzodiazepines. You can't wean off, if you're on Stilnox or you're on Zopiclone, you can't wean off without a replacement. And the safest replacement by far, in my opinion, is CBD and THC. CBD on its own, it's really difficult to wean off Stilnox. A CBD with a bit of THC gets most people over the line. For me, that's great.
That's amazing. That really is. Like,
So that's a typical scenario that I would see in my clinic.
That's using plant medicine to get people off highly harmful synthetic medicines. We love your work, Dr. Dev. We have loved chatting with you as well. We're conscious that you're a very busy man with a very busy clinic, so we'll and you've got to get to sleep as well. We're mindful of that too.
He's got a wife to make fall asleep as well.
Yeah, there's that.
I just listen to myself, so that's the way I fall asleep.
No, it's been it's been a great discussion. We really appreciate it. And for anyone listening out there who has issues with sleep, join the queue at Lullaby Clinic, because there's quite a few patients there that are interested in getting more of Dr. Dev's insights and expertise.
It's join the queue to get some Z's.
Yeah, CBD Z's.
CBDZ. Zebedee. I don't know.
Yeah.
That could be a new flower. Zebedee.
Yeah. Dumbo.
I'm still sticking with Dumbo for now.
You like the Dumbo Mumbo Jumbo?
I'm all about it, actually. Yeah. That's that'll be the new ones coming out.
Awesome. All right. Well, Dr. Dev, thank you so much for coming on, and take care, sleep well, and we'll see you next time.
All right. Cheers.
Bye.
Hey guys, Andrew Dowling here, Mitch Kurtz, and thanks for joining us for another episode of the AltMed podcast. Make sure to hit like and subscribe to stay up to date with all that we have coming. All things AltMed? Yeah, that too. Okay.